Well, good afternoon, everyone. I would like to welcome you to Bioethics Grand Round today, whether you are joining us in person or online. My name is Ishan Ma, and alongside Dr. Grace Wee, I'm co-director of the Center for Christian Bioethics. Through events like these Grand Rounds, the center seeks to strengthen the link between rigorous academic research in bioethics and the provision of healthcare. And the topic of today's Grand Round, I think, really attests to the significance and continuing relevance of bioethics thinking in the practice of ethical healthcare. And the mission of the Bioethics Center is to continue the teaching and healing ministry of Jesus Christ by uniting both scholarship in bioethics and the regular, and as well as the world of the clinical healthcare and medicine. And these bioethics grant rounds are critical to fulfill that mission of ours. And of course, none of this would be possible without your continuing interest in the work that we do, as well as your support for us at the center. So I want to thank you for taking the time today out of your busy schedules to be with us today. So there's a couple of things that I'd like to announce. One of these, we would like to give a thank you to the leadership of internal medicine for allowing us to use this space for their hospitality. And I would also like to thank our center administrative manager, Olivia Schultz, for her leadership and coordination to make this event possible. And for the support team here, technical support team, which allows us to reach a larger audience online. And in that note, I would like to also make a few announcements that, as you can see here on the screen, we do offer CME here. If you would like to claim the credit, please send an email to bioethics@llu.edu stating your name as well as your academic degree, and we'll make that happen for you. There is going to be a Q&A at the end of Dr. Ard's talk today. Between Dr. Ard's talk and the panel discussion, there will be an opportunity for you to, and I would invite you, if you have a question, to travel up to the two microphones here. And we ask you to do that partly because we have a virtual audience so that they can hear what you're asking, and so we can respond to that online as well. And if you're joining us virtually, feel free to use the chat function on Microsoft Teams. Submit your question there. I will be monitoring the question during this session, okay? So feel free to do that as well. And I was notified that earlier that some of you who are joining us virtually are seeing a distorted picture of the PowerPoint presentation. And how do you fix that is by right-clicking the image itself and by pressing full screen. And that I was told that would return you back to the correct way that you should view the presentation. So without further ado, I would like to now turn the time over to Dr. Grace Wee, who will be introducing our topic as in our speaker today. All right.
Thank you so much. Hi, everybody. It's my pleasure to introduce our speakers. We have Dr. Mark Ard. He's a degree in physics from UCSD, an MD degree from Loma Linda University School of Medicine, and a Master of Arts and Bioethics degree from Loma Linda University School of Religion. He graduated from the psychiatry residency here at Loma Linda and a fellowship in consultation liaison psychosomatics at USC in 2021. He's currently the medical director of the inpatient geriatric service at the BMC, as well as the psychiatric emergency service and inpatient consultation liaison service for LLU Health. He's part of our clinical ethics team, and in his spare time, he wrangles 5 children under the age of 8. Although currently in his house, I understand there are 8 children that you have at your house, which is why he's probably at work. I have a great pleasure of introducing Dr. Zane Ashman. He's a new faculty member in our Department of Surgery. He received a degree in cultural anthropology from NYU, graduated magna cum laude, before deciding to pursue medicine. After graduating with his medical degree from UCLA, he finished his general surgery residency at Harbor UCLA, while at the same time completing a Master of Arts in Bioethics degree from Loyola Marymount University. He then completed a surgical critical care fellowship at the University of Pittsburgh Medical Center an acute care surgery fellowship at UPMC. Have I missed any fellowships? And during her surgical residency, UCLA actually implemented their medical hold policy, from which our CHIP policy borrows from. So thank you so much, Dr. Ashman, for being able to be here and provide your clinical experience. And in Dr. Ashman's spare time, when he's not completing additional fellowships, he enjoys playing music and bass guitars. And lastly, I had the pleasure of introducing Dr. Leah Tudtud-Hans, known to many of us. Dr. Hans has a long history of distinguished service to LLUH in her capacity as attending physician, administrator, and teacher. Currently, she serves as the Associate Chair of Continuing Medical Education for Internal Medicine, in addition to being, as she told me, the longest serving hospitalist here in our faculty. I was once a resident on Dr. Hans' service, and I saw in her an exemplary role model for the kind of physician I strive to be. Many of us know Dr. Hans to be a devoted patient advocate, a seeker of truth, and a source of practical wisdom that can only be earned through reflective experience. As an ethicist, if I get a consult from Dr. Hans, I know it'll be a difficult question because she will have already explored and discarded all of the easier options. So I can't think of a better group of clinicians and experts here to introduce our policy on the medical hold. So without further ado, Dr. Ard.
Well, thank you for that introduction. Okay. Oh, I have a clicker. There we go. So when the chips are down, always good to open with a nice pun. This policy, M-147, the continued hospitalization of the incapacitated patients, we're going to see it in action. I know some people have already been seeing it over the last few weeks to months. As far as disclosures go, we have none. All the panelists said none. I would be really interested in what those actually look like. As far as the outline goes, I want to set some groundwork for what we're about to discuss. I want to review the proper use of the involuntary psychiatric hold, and I think as we do that, it'll be clear how it has been used and misused over the years, and discuss decision-making capacity mostly from an ethical perspective, but touch on some legal aspects as well, and then look at the conflicts that arise when we try to help incapacitated patients. And lastly, I have the actual flow chart, which we're going to walk through and hopefully help it make sense. And I will say, just Dr. Wee mentioned UCLA's policy. I remember being a young medical student at a conference in LA, watching UCLA present it, and Dr. Moore and Dr. Wee, we were sitting together, and I remember seeing this up there, and I thought, this is amazing that this exists. How do we get this? And this is now 10 years later, we have this. So it's been a work in progress. First thing we should do is really talk about what is an involuntary psychiatric hold, because it is a set of legal documents, statutory requirements, corresponding orders, and it's written by physicians or staff authorized by the County of San Bernardino to involuntarily detain a person. I have to go to a half-day training every 2 years. All of the psychiatrists and psychiatry residents are trained. Specific nursing and social workers are also trained to write these involuntary detainment orders. And it has very narrow criteria. So when writing this detainment, the patient has to be a danger to themselves, danger to others, or grave disability. And we throw these terms out there. And it has to be due to a mental disorder or suspected mental disorder. And we've kind of gone around what counts and what doesn't count. And we will clarify that a little bit here. We've chosen to see drug intoxication and withdrawal as counting, but oftentimes traumatic brain injury does not count. And what this is saying is, normally people are allowed to come and go as they wish. If I'm going to detain somebody, they have to meet these strict criteria, or that detainment is illegal. I am violating their rights unless I show that they meet this criteria. And not only is the criteria specific, but it needs to be goal directed, meaning I can't just detain them. I have to assess, evaluate, and give them crisis intervention. I'm obligated to do that, or again, I'm operating outside of my protection under the 5150 law. And during that time, I have to try to transfer them to a designated facility. So in our case, that's the Behavioral Medical Center. The VA actually has a whole unit dedicated to inpatient psychiatric care, so their whole hospital would qualify as an institution, but specifically we're trying to get them a type of care that they need. So again, if I'm detaining somebody without trying to get them this care, I am not protected. There are two specific laws that we look at, and these should sound familiar. The first one is 1799. In its essence, it says the patient is currently at a medical center, but they need to be at a psychiatric facility. It's actually kind of copy and pasted from the 5150 law to say, look, what if they're not at the right institution? So if you're at a medical center, but you need psychiatric care, and you're medically stable for discharge, I can detain you for 24 hours. And I stopped there just to look around the faces of everybody that has ordered a 1799 and say, did all of these criteria, were they all met? And my guess is not all the time. It is a good tool, you just click a button, but it has these narrow criteria that are supposed to emulate what the 5150 law says. And so similarly, under the Welfare Institution Code 5150, I am evaluating somebody that is already at a psychiatric hospital, or they're en route. So this is made for peace officers to write 5150s out in the field, or APS, CPS, social workers to write it and then bring them in. Or they're in an emergency department for medical clearance. I can write a 5150, but again, I think they need to be at a psychiatric facility. I can detain them for 72 hours. And again, they have to meet those strict criteria we just covered, and I have goals when I'm detaining them. So I tried to narrow it down to just kind of some tests. So if I were to ask you, regarding this patient's medical or surgical condition, are they stable for discharge? Or would you discharge them against medical advice? If the answer is no, then this isn't so much a question of psychiatric care, this is a question of medical care. And if you would discharge them, do you think they need continued mental health treatment at an inpatient psychiatric hospital? And if you do, are they trying to leave? Because oftentimes they come in for medical, surgical emergencies. We stabilize those, and they mention, suicidal thoughts, or they seem gravely disabled due to a psychiatric illness, but they're actually asking for help. And they're willing to wait to be transferred to an appropriate psychiatric hospital. They don't need to be detained. There's nothing to detain. Our team is actively looking for a place for them to go. So if they're trying to leave, but you're trying to get them to psychiatric treatment, you can order a 1799, and you get 24 hours. And I see some of our case management, social staff, or social workers in here. How difficult is it to get somebody from a medical floor to an inpatient psychiatric hospital within 24 hours? Very difficult, right? And again, this narrow criteria says as long as all the other things are met, I can detain somebody. And then the other question is, if they're not admitted to the medical hospital, if they're outpatient or in the emergency department, only a specific person can write that 5150, and you get them for 72 hours. I think that's helpful to just give a background on what we can and can't do from a psychiatric standpoint, and recognize there's a big open hole in this policy and how to deal with people that are incapacitated. So that's helpful to transition into this topic of capacity. And I want to do so. I know we have some cases to review, so I'm not going to go into all the details of this case, but I think it is instructive because I think people have experienced similar situations. In a 2006 article titled "Involuntary Hospitalization of the Medical Patients Who Lack Decisional Capacity," it is an unresolved issue in 2006, which is a long time ago already. They present this case of a 46-year-old woman with multiple medical problems, dementia, found to have hemorrhagic brain lesion, delirium. She's on hospital day 5 and tries to leave. Some people are nodding their head, like I see this all the time. Police were called. They refused to restrain the patient, stating, quote, they could not be restrained or kept in the hospital against her will without psychiatric legal commitment documents. They need somebody to write the 5150. And so they call the psychiatrist and they do it. I have been in that exact situation and been with my back against the wall and hearing that support staff are unable to help because there isn't a legal justification for what we're doing. And in the words of Anna from Frozen 2, you just do the next right thing. This is also not good policy, by the way. This shouldn't be how you handle difficult cases. But you know what? In a situation like that, this might be all you have. So my hope is, as we review this policy, we could do better. So if we're assessing capacity, it really comes down to their decisional capacity, and they have to demonstrate specific component tasks. And I think it's worthwhile to review them because this is what should be happening when somebody is asking to leave the hospital or refusing treatment or accepting treatment. You should be evaluating their decisional making capacity. And the first thing they have to do is express a decision. What do they want to do? Somebody who's pulling off their IV and electrical leads and trying to leave, they might be showing that they want to leave the hospital or saying, I want to leave. This is their decision. Do they understand the relevant medical condition commensurate with their level of risk inherent to that decision? Meaning patients don't need to know what a cholelithiasis is, but they need to know something bad with their gallbladder. They don't need to know all the details of dialysis. They do need to know that if they don't have this dialysis, they might die. And as they explain their choice, they have to appreciate and appraise the risks and benefits of that decision, as well as alternative options. If any of you have had the psychiatric team or the ethics team come do decisional capacity evaluations, oftentimes we ask the primary clinician to be there because I don't know what the risk, benefits, and alternatives are, and it might have been explained in a different way. I like to actually be there for that conversation to mediate between the two and see, you're allowed to say cholelithiasis, but I want to help them understand what options are available. And then as they're doing this process, they have to demonstrate a reasonable and rational thought process. Reasonable being, is this what somebody would do in this situation? And then as they're connecting the dots between their choice, their understanding of that situation, and their appreciation, are they using a rational thought process? Oftentimes this is why a psychiatric consultant comes in, is because I don't think they're demonstrating a rational thought process. And then is it consistent with their past or known values that they've made before? And this is important too. Somebody who completely flips on their decision should cause you pause to see, what am I missing in here? And so when we think of incapacity, it's due to a lot of things. The ellipse just says you can come up with your list, but I think the ones that are most common, traumatic brain injuries, we just talked about. I was talking with somebody else here about a stroke leading to denial of their illness. This is quite common, right? Seizure disorders, infection, somebody with severe sepsis, cancer, especially if it's metastasized to the brain, they're likely to not be able to demonstrate that capacity. And then, this 40% number, I'm not a big fan of it because the data where this comes from says, they went to medical surgical wards and they asked patients questions and they said about 40% of them don't demonstrate the capacity. And that's it. They don't exactly explain why. I do think that it really does depend on the decision that they're making. People can choose, the type of dinner that they're going to have, but they might not be able to consent to surgical procedures. So it is very decision specific. But I think this 40% number is somewhere in the ballpark to say a lot of people are not able to make some of the really important decisions that we ask them to make. One of them being trying to leave the hospital, which oftentimes is the most important one. We can slow down and talk about consent to procedures, but you gotta stay in the hospital. We have data looking at the use of the 1799 over the last couple of years to detain people, because that's what has been used historically, and it shows, maybe as much as 2 per month that are trying to leave the medical surgical floor that the primary team will utilize a 1799 to detain them. That number might be higher. We're kind of picking through exactly what qualifies that 1799 order. And then there are lots of times where you kind of convinced them to stay and they never got the 1799, but we were getting close and we don't have numbers on those. So before the continued hospitalization of the incapacitated patient, what did we do? So if you're medically incapacitated, but you attempt to leave despite the grave risk, you have 3 options. You can just let them go. Try to remind people that even if a patient signs an AMA form, the assumption is they had the capacity to make that decision. So leaving AMA is risky. You could also request an involuntary psychiatric hold if that resource is available. So in the hospital here, you can click 1799, you can call psychiatry to come see them. You can order staff to just detain the patient. So okay, let's look at those real quick. If you discharge them against medical advice, first of all, probably not a good idea, right? If you have decided that they are incapacitated to make that decision, against medical advice is very risky. And I think most people don't want to do that, right? They recognize the risk. And so they don't feel comfortable saying, sign this piece of paper, it's your life, right? I don't think that that's what we do. And it is ethically wrong. You do have a duty to protect patients from harm. You have a duty to act in their best interest. And legally, you've opened yourself up to this question of neglect, right? You had a duty to care for somebody who's incapacitated. You had a dereliction of that duty. You failed to detain them and care for them. If they leave and are harmed, either their medical issue worsens, depending on their situation, they could walk out into traffic and get harmed. If there's a damage done and it's connected to your evaluation that they were incapacitated and then not detaining them, you're open to legal risk. Okay, so other options. You place them on a psychiatric hold. It gets you 24 hours. And during that time, and I mentioned this, the case managers, social workers, you have to get them into a psychiatric hospital. The clock starts, right? Patients have judicial mental health rights. I mean, there's a lot of benefit or a lot of protection you get when you're psychiatrically detained. You have patients' rights advocates. You have the ability to ask for a writ of habeas corpus and go to court and argue why you don't need to be detained. So a lot of these protections should be afforded to patients that are put on psychiatric holds. And I just mentioned this more recent article, 2019, The Doctor as Jailer, specifically pointing out that, look, when you put somebody on a psychiatric hold, you're exposed to false imprisonment, right? The 5150, 1799 laws say you're going to be exposed to false imprisonment, but you're protected if you meet certain criteria. Those criteria are, first of all, you have the privilege to do it. Not everybody has that. So don't go writing 5150s just because you have the piece of paper. You have to justify that mental health disorder and show the danger to others, danger to self, grave disability. And you have to document all of these things. Because if this is not a psychiatric condition, writing a 5150 to keep an incapacitated patient or clicking 1799 and everybody swooping in, this isn't psychiatric. You're treated just like any other person under tort exposure. And they don't authorize medical treatment. I think this comes up often too, is just writing a 5150 or 1799, even if it keeps the person here in the hospital, there's a lot of other things you have to do. Usually these incapacitated patients have complex medical care, that's why they're at the hospital. And so the discharge planning options can be negatively impacted, right? If you have somebody who had a stroke and they might need memory care as their ultimate disposition, very difficult to do that if now you have documentation that they were placed on a 5150 because they were agitated for a brief moment. And then there comes this game of hot potato when you get to conservatorships, because there's two separate pathways, the probate conservatorship pathway that's really meant for the patients we're talking about, and the Lanterman-Peters Short, the LPS conservatorship pathway that says you need to be psychiatrically conserved. If you throw a 5150 or 1799 in the mix of a medically ill patient, it's not really clear who the best conservatorship is at this point, and we've run into a lot of issues getting the right conservator because of psychiatric holds in the past. And then, of course, this last plan, just detain them. Obviously, we talked about this risk of false imprisonment. There is no legal basis for detaining such patients. There's no law. This nice thing about the 5150, it's right there in the law code. Many physicians won't do it. And even if they will, security won't do it. And nurses won't let you do it, even if you try. Also, because they're the ones that have to do it, right? It's really easy for me to click a button and then step back and say, okay, security, nursing, tie them down, give them shots of medication. It's very uncomfortable to put them in that position. And then what is the standard of practice when detaining somebody, right? You really, really want a hospital policy to address this involuntary hospitalization. You don't want to just be doing the right thing every time. You don't want this, Chicken Little effect every time a difficult case comes up. You want to be able to point to something. So what is that thing? It's this flowchart. I love flowcharts. What do you do when you have an adult patient attempting to leave the hospital You've done a decision-making capacity assessment, and you ask, do they demonstrate that decision-making capacity? If yes, you let them go. That's the appropriate thing to do, right? Maybe they sign an AMA form because you really think they should stay. Maybe, you agree to disagree, but it's not that significant. But if you think they don't demonstrate decision-making capacity, and you think this may be due to a psychiatric illness, call us and order the 1799. I think it's appropriate to order that if you really do think this is a psychiatric illness we're talking about. And then we will come in, we'll evaluate them, and if appropriate, we will continue that 1799 and we will move mountains to try to get them to an approved facility. But if you don't up here does not have decision-making capacity, and they have a surrogate decision-maker, somebody else can decide for them. Either they've identified this person previously, they have a durable power of attorney documentation, maybe they're conserved already, and you have a surrogate who consents to detainment, then go ahead and detain. The surrogate decision-maker is making that decision on their behalf. And if the surrogate says, I'm okay taking on this responsibility, I'm gonna take them home, and they're able to make that decision, the surrogate has the decision-making capacity. It might be an AMA discharge. This happens often for caregivers of our medically ill patients. If family really can make that decision, we do let them go. It's the ones that don't have a surrogate decision-maker and they need to be detained. You go ahead and order the CHIP, continued hospitalization of the incapacitated patient. If it turned out to not be psychiatric, or they don't have a surrogate decision maker, or the surrogate does want them to stay, all roads lead to CHIP. It is now just, this would have been nice to actually have a slide of LEAP, but if you go into LEAP and type legal orders, it's now one of the options is CHIP, and it says CHIP involuntary. And it is indefinite in some sense because it really is meant to be there for the length of the medical condition. We say that after 4 days, if you're still detaining them, consult ethics, and you can do so earlier if necessary. You can also, consult the appropriate second opinion if you want. But ultimately, the safeties are in place to say after 4 days, you should really bring ethics on board. And that's it. My hope is that this captures a significant population that are trying to leave the hospital. There's plenty of more work to be done. If they're acutely agitated, we have policy M91. If you're trying to figure out who the surrogate decision maker is, we have M131, P2, P23, all these different options to say who can decide for this person. If there's an emergency, P8 kind of outlines how to handle that situation, and there's statutory code saying this is what you can do to handle emergency situations. If you need court orders for a big medical treatment that's not emergent, there are legal pathways to get a court injunction and have a judge decide on this, usually relatively quickly, within a week or two. And then if it is a psychiatric issue, well, you have M-147, which is for psychiatric emergencies, and then we talked about 5150, 1799, and then there's pretty clear conservatorship pathways, which we have applied for conservatorship here in the hospital. There's a lot of other options. M-147 says, let's just keep them here while we figure out the next thing to do. And lastly, I want to finish with this before transitioning to the Q&A, is just to say, look, we need to figure out what to do with expiring holds. If this really is a psychiatric situation and you've run out of 24 hours, but they're medically stable, what do we do? What do we do for the patient that's here for COVID and they're asking to leave 24 hours later? What about the in-betweeners, right? Neurology tends to steal all the good diagnoses from psychiatry, but there's a few that we're not quite sure whose this is. And then we do need to do good data collection. One of the big reasons for having a button that you can push is just so we can review these cases. And then I would just say, keep an eye on this Senate bill that's working its way through. It's going to change the definition of grave disability to include inability to care for basic personal needs and medical care. Right now, psychiatrically ill patients cannot be detained because of inability to manage insulin. So I think that this will become big in the next year, and it will change how we think about these issues. So all of this to say, there's still work to be done, but hopefully this adds another tool in your arsenal We're going to discuss it here on the panel. If you have questions, send me an email, send me a secure chat. I'm here to help clarify this. The ethics team has worked on this for over a year now. They're all well versed in it. So hopefully this has been helpful for you. So thank you.
Thank you so much, Dr. Ard. For those who are attending online, we have a number of people who are attending online. Please feel free to add in your questions. So we have a couple of questions. Mark, yes.
No, those questions before the panel. Yes, yes.
There's questions before the panel.
Okay, I'm
yes.
ready for those.
Oh, okay.
Go for it.
All right, so the first question is, does the administration of a medication such as Zyprexa or Haldol given to an agitated patient placed on a 1799 count as unauthorized administration of medical treatment under current law?
That's a great question. I want to make sure I clarify. If they're on a 1799, you are saying that they are medically stable for discharge, but you're detaining them while seeking inpatient psychiatric hospitalization. And if you're talking about use of those medications for management of their psychiatric illness, such as schizophrenia, bipolar disorder, you are not allowed to give it involuntarily. If they become agitated or they're attempting to harm themselves or staff, it falls into emergency treatment and you're using it to manage that agitation. That can be given without consent. You really should pursue, one of the last slides is actually the law code for involuntary psychiatric medication, but it's the Reese hearing. It's a legal pathway to involuntarily give psychotropic medications. You really should go through that pathway to treat bipolar or schizophrenia involuntarily. Under CHIP, or the incapacitated patient in general, oftentimes we use these psychotropic medications to manage agitation or help with the symptoms of delirium. That is not a psychiatric question. That can be given without the consent of the patient if there is a surrogate decision maker or another process that we're using to get consent for that. Hope that's helpful.
I think a question like this can be teased out a little bit more during some of the cases that we can discuss too. Here's another question. Is there a process or set of criteria for evaluating the decisional capacity of a surrogate?
Oh man.
How much time do we have?
I know. I don't have a frozen tooth clip for that. It's difficult because I think that oftentimes we have a really ill patient and we hope that family is a good decision maker and we have that conversation. And this is just as difficult and they're awake and interactive. I would use the same criteria. I mean, one of the big ones is they have to be representing their loved ones' interests or decisions. Oftentimes, what we'll see is the incapacitated surrogate is usually trying to project their own views of something onto their loved one instead of making a surrogate decision. So it's hard. Call ethics for that. Yeah.
We can help you out. I want to invite the audience, if you have questions, we have microphones set up here. Feel free to come on up and ask a question. We'll be starting to discuss some cases, and so if you have a question that comes up in the course of your case discussion, then again, please feel free to ask questions. So I want to invite Dr. Ashman to come up, and we'll go through our first case, which is a surgical case. So this is a 31-year-old male. He was brought into our ED by EMS as a trauma activation after being hit by a car. He'd actually been wandering into oncoming traffic when he was sideswiped by a car who had actually been trying to avoid him. And his injury list includes a complicated fracture of his pelvis, suspected arterial bleed from the pelvic vessels, as evidenced by multiple requirement for blood transfusions and hypotension in the ED, right-sided rib fractures, and a right pneumothorax. In the ED, they placed a chest tube, and he was taken emergently to IR for embolization and then to the OR for repair of his pelvic fractures and the bleeding artery, and both of these procedures were done under the emergency exception to consent. Post-operatively, he's doing okay. He's got waxing and waning mental status. He does require a one-to-one sitter for agitation. He has a brother. However, his brother does not want to be involved in his patient's medical care. And then the brother then requested our team to no longer call him. The patient does not have any known psychiatric history. And then in talking with the primary team, they're really recommending that the patient be discharged to a skilled nursing facility for continued rehabilitation. Again, he's 31, fairly young, and has a good potential for rehabilitation. So today, it's now 4 days after admission. He's post-op day 3. He's insisting that he needs to go to the hospital because he needs to go pick up his dog. He needs to rescue his dog. He's very concerned about his dog. The trauma service attending evaluates him and concludes that the patient actually doesn't understand the full consequences of leaving the hospital now. Although he's able to ambulate somewhat, he should be doing it with physical therapy. He's partial weight-bearing status. The service attending just does not think that he understands the full ramifications of leaving. He becomes verbally agitated. The nurse pages the primary team. The patient then gets out of bed, walks past the sitter, starts for the hallway and the elevators. So now the question is, what can the primary team do when they arrive? So first of all, is this a case that perhaps rings a couple of bells? I'm seeing some head nodding.
Yeah, for me, absolutely. So it sounds like this guy, he wound up in the hospital because of some unknown psychosocial issue. He doesn't carry an active psychiatric diagnosis. He may have, impairment from drugs or alcohol. He's estranged from his family. So he meets kind of all of the criteria that one would expect with a trauma patient.
So if he doesn't have decision-making capacity, I guess one question is, why can't we just consult psychiatry to put him on a 5150 hold?
Yeah, I mean, I think that...
I think we saw him.
Yeah, I'm sure we've seen him in many different iterations. And I think that traditionally that would be the pathway. Is kind of our own internal algorithm would be, what does psych think? Why is he acting so strange? He doesn't have a psychiatric diagnosis, but he wasn't normal when he was playing in traffic, and he's not normal now.
Well, I think too, when we first heard about this policy at UCLA, their concern was, is there misuse of the 5150 law, because UCLA Hospital is actually all a psychiatrically designated facility. And it is very tempting to put somebody on a psychiatric hold. There is a direct pathway for conservatorship, 5150, 5250, 5270, temporary conservatorship renewed every year. If you kind of grab them with that umbrella, like you can keep it over them the entire time. So when UCLA looked at this, they said, are we misusing the 5150 pathway? And they said they found, yes, we were. That's why they came up with the policy. In our situation, you can call psychiatry and we'll get you 24 hours. But the 1799 is not as powerful as the full 5150 pathway. So historically, we've used it because it will buy you time for somebody walking out the door. And then also the question is, what do we call a psychiatric illness? Because I agree, when I see this, it's oftentimes usually stimulant intoxication or withdrawal, and then a strong component of either a primary psychiatric disorder like schizophrenia, depression, bipolar, or just a personality structure that does not want to be locked up in a hospital. And which one of those are psychiatric conditions saying I can put you in a psychiatric hospital? But I think that last part is the important one. Put you in a psychiatric hospital. Your goal here is to get him to skilled nursing rehab. Mm-hmm. So using the psychiatric detainment at all really doesn't achieve the primary goal of medical care. It just buys you time and gives you a false justification for detaining somebody.
And I think his waxing and waning status would argue for delirium more than anything else.
Or some sort of traumatic brain injury, which is reversible and would not qualify under a inpatient psychiatric hold.
I'm curious, actually, this term decision-making capacity comes up a lot, not so much for treatment of medical issues. We have the P23 policy that brings together a multidisciplinary team to consent on a patient's behalf for surgical interventions or even to discharge them. But in a situation like this, what are we testing the capacity to do? What are the, I mean, this was a previous question. What are the goals of that assessment? Because there's not anything active that you're trying to do. So I guess when you say he doesn't demonstrate decision-making capacity, what is the evidence for that?
Yeah, so in this particular patient, 4 days out, he might still have his chest tube in, he might still be on oxygen. He's definitely requiring some physical therapy. Yeah. And I think that the real question is, if he walks out, is he going to be able to breathe, and is he going to lose some degree of ambulatory function? And so I think you're exactly right that our question, the threshold for deciding capacity really kind of pertains to the question at hand. Right. He clearly has capacity to make decisions about whether he wants to eat dinner or not, right, as the point that you made. But in this particular case, his perseverating on the dog and his inability to really kind of describe what his plan is in terms of regaining his ability to walk would argue for this lack of capacity.
So if he doesn't have capacity to make a decision to decline continued hospitalization, we have a policy called P23, which you brought up. So by the way, P23 is our policy, which is medical decision-making on behalf of the unrepresented patient. And an unrepresented patient is a patient who does not have a surrogate decision maker, and also a patient who does not have decisional capacity to make the specific question at hand. So it would seem like he would qualify to have medical decisions made for him per P23. So why would we need this additional policy, or what does CHIP provide that the prior policies that are already in place would not?
Yeah.
Well, what is the movie Click, right? Where you got the remote control that can stop time. That's what it is. Because oftentimes gathering the people to make important decisions takes time, and on the way out the door, we really need to know what to do in that exact moment. And I think about the conversations I've had with our legal team, and they've joked about, if you're gonna call me and your options are, I have neglected the patient by letting them walk out the hospital despite clearly thinking they were incapacitated to do that, or you're gonna call me and say, look, I had to detain somebody and it might have used restraints or medications to help calm them down. They are asking to leave, but I overrode that. I haven't got a hold of the surrogate decision maker. We're waiting for this P23. I did what I had to do. I did the right thing. If you're gonna call our legal team, they would sure like to protect or defend the second one over the first one. Even better than that would be, I utilized a policy that's been in the making for years and has been reflected on and has tools in place to check itself and gather feedback. They would really like utilization of a tool like that. So ultimately, doing the right things has its risks, but the point of this CHIP policy is to give you something to do right then, right there, to mitigate the situation as you figure out the next thing to do. I will say too, there's other policy to use after you've detained them, so this isn't the full solution. But yeah, they're difficult situations, and I would say, to the question about capacity, I like the best case scenario test, especially with discharge. It's the patient will tell you their plan. Imagine the best case scenario of that plan. If that doesn't even work, this is probably not a safe discharge. So this is the person, that is having to use full assist, that their plan is to go home and be completely independent. In this guy's case, you're asking him to explain how you manage all of these, traumatic injuries, and he's just focused on the dog, right? You need to demonstrate a best case scenario that I can get behind. And if you're not able to, this is the way to stop them from leaving.
So the patient is literally getting up and walking past the sitter, starts for the hallway and then the elevators. What can the primary team do immediately?
CHIP.
So just implement implement this policy.
And this is the point of this talk too, is to make sure we're all on the same page about what this equips everybody to do. This is call security. This is having nursing staff ready for what might be an agitated patient, if they need medications, if restraints need to be used. Everybody is gearing up for what needs to be done, and it falls under this policy of detainment first, so we can figure out the next steps.
And what are the limits of what kind of detainment can be provided or medical treatment that can be provided under this policy? Like, for example, can we measure him for a specific brace that he needs for his pelvic fracture, for example?
Right. So based on our conversations, it sounds like Chip is going to keep him here. But let's say he develops retained hemothorax and he needs a VATS or something like that. Then we would turn to the P23 because it's not an emergent condition, and if he still, no longer has capacity.
And if it becomes an emergent condition, we have policy for that too. Right. You might need to intervene very quickly. And interestingly, there's a good amount of case law defending that, where the physician has to intervene very quickly for an emergency situation, is unable to obtain consent, or the patient refuses but obviously is unable to provide that consent. That is a situation where doing the right thing is really protected. And our legal team, would say the same, is that if those are the criteria for your emergent intervention, that's what you have to do. CHIP just says keep them here.
Right, so that would be the emergency exception to consent. So again, just trying to equip all of our clinicians here with tools so that we can do the right thing for our patient. Fantastic, good, thank you. Okay. Dr. Ashman, I want to invite you to come, so stay up here. Dr. Hans, please come up. Let's go to our second case. If any of you are wondering, oh, well, I'm not a surgeon, I'm an internist. So this is a case written with an internist in mind. 64-year-old female, past medical history of poorly controlled diabetes, hypertension, coronary artery disease, peripheral artery disease, diabetic nephropathy, chronic kidney stage 4. Did I miss anything? Lives in aborted care, was found acutely altered, brought into our ED where she was diagnosed with sepsis secondary to a urinary tract infection, and also pretty severe right foot necrotizing soft tissue infection. They started her on antibiotics, resuscitated her, admitted her to the internal medicine hospice service. They get a vascular surgery consult, and vascular surgery says, you know what, based on her history and the extent of the infection, we don't think that this is a salvageable limb just by antibiotic therapy alone, and we would recommend an amputation. They explain this to the patient, but then she becomes very agitated, she declines. Because of the agitation, psychiatry is consulted. Psychiatry sees her very quickly, and the assessment they leave in the chart is she has acute encephalopathy, likely multifactorial, likely personality disorder, but really no diagnosable psychiatric condition other than what has been written. They do not think she has any need for inpatient psychiatric care, and they do recommend instituting delirium precautions. Dr. Ard, would this be a type of psychiatric assessment that clinicians would find?
When I'm reminded that middle bullet point, when I was a resident, I remember making templates for how often these came up. I want to just be able to type something in to say, person's confused. And I think that does an injustice to the real question you're asking. I think you can diagnose delirium quite well. That's not the concern. It's what do I do in this situation? So sometimes I make the mistake of coming in and clarifying a diagnosis and walking away and saying this isn't a psychiatric problem. Even if it's not, it's still a patient that's in need and has a complex situation. You mentioned before, if Dr. Hans calls this, it's probably a complicated case. So when I see this, my question is, where is she trying to leave? Is there a need to detain this person?
Well, yes, because today she accuses a primary team of wanting to chop my foot off. She loudly says the doctors aren't doing nothing for me. She states her desire to receive care at a real hospital and then physically starts to leave. The nurse pages a primary team. What can the primary team do when they arrive?
So this would be someone, if I understood your talk, we would place on a chip. Yeah. I think we may not have been using the 1799 correctly in the last couple of years, because you made it very clear that the 1799 includes a psychiatric condition. In this case, this is a medical condition that's causing the confusion. So we should put a chip in this patient.
And I have definitely been at the bedside of these cases where staff is waiting for some order to
Correct.
justify that detainment.
Yes.
And you can go back and forth, and as the patient's walking out, it's really seductive to say they're on a 1799, right? Just click a button, and the button pops up, there's a legal order, everybody feels justified in what they do. The analogy that I try to think of is like, this is like getting in your car and buckling your seatbelt, but the other end is not plugged into anything, and driving around thinking that you're safe.
That's right.
Because I buckled. As soon as an accident happens, there's no restraint. The same thing here is that just clicking the button makes you feel like you're justified in doing what you're doing. The 1799 makes it feel like you are. If she had followed through with, you know, a legal case for her detainment, our argument cannot be 1799 justified what we did, because the psychiatric team saw her and said, this is not a psychiatric issue. We're not seeking inpatient psychiatric hospitalization. There might be other reasons to justify what we did, but it can't be the 1799. So the chip would be the same type of tool. It's something that you can implement quickly, that we should all be aware of exists, and we know kind of the rules around it that say this is a way to just keep them here while we figure out what to do. And hopefully that confusion from ourselves, from police and security, nursing staff, you know, the sitters, like everybody's on the same page that this tool keeps them here in the hospital.
She's acutely agitated though. So Dr. Hans and her team, they come up and she's starting to be just really not a nice person in terms of behavior. Can antipsychotics be administered to this patient?
No. Maybe. Maybe.
And this is a purposely vague question because, you know, these are sorts of the clinical things that come up.
I guess I do want to say too that I'm wary that the tools that we have create the landscape that we work in. If you have something like the CHIP order, that doesn't abdicate your duty to talk to the patients and try to convince them of what they really do need. The same thing with antipsychotic treatment. Somebody who's just belligerent and angry isn't somebody that you give a shot of Haldol to and it solves the problem. You have the obligation to still try to de-escalate the situation and try to figure out where their anxiety is, where their frustration. Can you address some of these problems? Even just sitting down with them and listening and empathizing with them. But if you've done that work, or you can't even get to that point because of, you know, this belligerent agitation, there might be a time where, you know, medication and or restraints are appropriate, and it does fall under our policy for agitated patients that says we do have the ability to use these things. So I think, yes, you know, you do as a last resort.
So yes and.
Yes and.
Yes and.
So you said the chip does not have, there's no time period, is that correct?
Correct.
For as long as the situation is needed. Obviously, it doesn't cover surgery.
It doesn't cover consent for surgery?
Consent for surgery.
Right.
We have to do a P23.
P23, right.
In that situation. How about if the patient is stabilized and is now ready to go to a facility? Is that also a P23 then? To transport her back to the transport and placing the patient in a facility?
Well, like the first case, if they're trying to leave, if they're unwilling to stay for transfer to the next level of care and they're trying to leave, that would be CHIP. That would be the time to detain them from leaving, because part of your obligation starts with the moment they walk in to the moment they're discharged to the appropriate level of care or against medical advice for a capacitated patient. So if you've medically stabilized them, but the next level of their care is a skilled nursing facility, if they're trying to leave, they might not be able to manage wheeling out on the street. So that would be a time to detain them. But if they are willing to stay and they are willing to go to a nursing facility, or they're not, you know, they're not trying to leave, they're not agitated about that. But who is consenting to the transfer to a nursing facility? The surrogate decision maker. And if we can't find one, the P23 committee. So there's the hope here is that CHIP says stay, all of these other tools come into place to figure out how to best manage agitation, consent to treatment, consent for placement, and those tools have all been there for years. It's just as they're walking out the door, what do I do? But there is hopefully this constellation of tools available to handle these situations.
Okay.
Thank you. I want to open it up to questions from the audience. I'm not sure whether there's, actually don't see any additional questions on the chat. So we will then give the last few minutes to our clinicians. Based on your clinical experience, what sorts of patients do you think that chip would really be beneficial for? And as you are guiding learners and younger clinicians, what do you hope clinicians would take away from this?
I think the point that you raised about talking with patients and trying to get to the root of their unwillingness to stay, the root of their desire to avoid our recommended course of treatment is really key. All of these policies are kind of last resorts. And so if I can convince, our trauma patient that his dog is safe and that is not an issue, and if he wants to be a good dog dad, he needs to take care of himself first and foremost. And we never even reach the point of having to deal with CHIP. That is the ideal solution.
I love that. Thank you.
Yeah, I think it's important to educate everybody, physicians, students, residents, nursing staff, case managers, to really understand what this is all about. I think there's so much chaos, at least in my world. The patient is screaming, running up and down. Some of them are very big. Staff, myself included, feel intimidated because of their size. So I think to continue this process of talking about this, all these issues, the CHIP, what is a 1799, and to feel comfortable with actually implementing the theoretical aspect is very, very important. I don't think we should end with this conference. I think this should be an ongoing discussion, branching out into the different departments.
Yeah, thank you. So this is just the beginning of our efforts to let clinicians know of the tools that they have available. Thank you. Dr. McCluskey.
Thank you for a great topic. Presentations very much needed. Your last comments brought to mind the concern if they're under a CHIP in terms of their just before discharge, they still have that need to be under a CHIP protocol. And people were giving the maybe drugs. How are we going to gift that patient to an outpatient facility? What are they going to do? Because they don't have all these committees, they don't have all our protocols. P23 may say, sure, they're ready to go, but can you just comment if that's going to become a new barrier, or are we able to just endorse that med regimen to them as well?
And maybe you can correct me if I'm wrong here, but my understanding is that some type of facilities, like skilled nursing facilities, do have pathways to detain incapacitated patients that are not yet conserved. Oftentimes the P23 team is getting them into those facilities, and then they have their own mechanisms. Same with like memory care. Mm-hmm. Certain acute rehab facilities have these mechanisms in place to detain patients that the CHIP would have been used here. Long term, the answer might be pursue conservatorship. And at least getting that ball rolling in this setting as they transition into the next phase. But that is a good question. This is our policy. This is not a state policy.
Yeah, I don't think there's a great answer, Dr. McCluskey, and we have seen many examples of care. The continuity of care is very broken when they get transferred out from the acute care setting into a longer-term care facility, unfortunately. But yes. Yes, hi.
Thank you so much for explaining that, and really appreciate the talk. Something I'm in addiction medicine, and Dr. Chon, something I run into is a lot of times patients in my realm get cleared medically and probably cleared psychiatrically, but when they were intoxicated, they were making choices that were less than desirable. That led them to either a place where when under intoxication, like they were either like suicidal or put themselves in danger medically. Do you guys know of any policies that for patients, especially for that impulsivity that affects so many of our patients? is there any policies that are kind of directed towards that kind of avenue, if that makes sense? Like they still have an active substance use disorder, but no longer like active withdrawal, maybe cleared medically and psychiatrically. It's a care gap we run into a lot, I guess.
Oh, wow, great question.
Yeah.
So just to clarify, this would be the patient that's not acutely intoxicated,
Right.
not withdrawing, but if they leave, they're going to relapse, and that'll
Yeah.
lead to,
Yeah, they were, for example, like people who are suicidal while they were intoxicated, but then they detox and they're like, okay, like I'm okay now. And it's like, it kind of comes in a question of capacity. Like they kind of have capacity now, but it's also like it's a shaky capacity. Put it that way. It seems like.
yeah, I mean, I guess one could argue that people in active addiction don't have capacity regarding their substance of choice. And that is a difficult spot. Yeah.
You know, I think it's helpful to just harmonize a little bit the ethical question of capacity and the legal tools that we have to detain somebody, because ultimately we're talking about the same thing. We're saying somebody who is making a decision, but we don't think that they understand or fully understand, they're not appreciating the risks, benefits, and alternatives of that decision, and their reasonable, rational thought process is impaired, either from active intoxication withdrawal or chronic exposure. That is the ethical capacity umbrella we're under. And then in the 70s, California decided to pass the Lanterman-Peta Short Act to try to codify this. And in my mind, I see it under capacity. Somebody that I am detaining, I am de facto saying you don't have capacity to leave from here. I am going to stop you from going because I think you are a risk to yourself, others, or gravely disabled. The law says I am protected when I detain you if I have shown probable cause, the legal standard of probable cause. There's almost the flip that says if I don't use that tool and I let somebody go, on some level, I might be open to neglecting them because I should have caught that they were incapacitated and I should have detained them. And there are cases on both sides of this. Classically, the Tarasov rule comes from this. You let somebody go who was a danger to somebody else, a harm happened, and the therapist was held accountable for that. So I am cognizant of that a lot, and I actually think today we work together with somebody who was in that exact situation. And in talking to somebody who says, I know that I had a gun in my hand while drunk, I don't feel that way anymore. I'd like to go home. My wife is there for me. I'm gonna follow up with all the substance use resources you gave me, et cetera. On one hand, statistically, I know that might not work out, but also, if I detain you, is this really in your best interest? Is this the help that you want? You're not asking to go to a psychiatric hospital, you're asking for substance use resources. So I'm very torn in that situation, how to approach those, and there's liability on both sides of that, but the ethical liability, like if I misread this, somebody can get really harmed. And also to say, man, our psychiatric diagnoses, they're criteria in a book, and it's really hard for me to fit some of the complex cases we have to those criteria. And you know, addiction is a big one that says these are conditions that are incapacitating people, and we don't have good pathways for that. Ideally, this could still be used for the very severe addicted patient who is completely neglecting their medical issue and trying to leave the hospital, whether intoxicated, withdrawal, or just kind of their baseline attitude towards things. But yeah, it's not clear. You know, some states do allow more detainment for drug treatment. California tends to not. I don't believe we have locked addiction units in California, and we all think that maybe there are some people that would be helpful for. So yeah, it's difficult.
Thank you.
Thank you so much. I appreciate that. Thank you so much for attending our bioethics grand rounds. This will conclude our session for today. I want to invite you to keep your eye out for upcoming programs. If you want to ask our panelists some questions, please come on up and let's continue the conversation. Thank you, everybody.